Hello and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss a novel treatment for BPH called iTind. Unlike some other treatment options for BPH, the iTind procedure is performed in the clinic setting. It involves inserting a tiny device through the penis with a flexible camera. The device is then removed in the clinic about a week later. iTind is one of the least invasive procedures for BPH. It's rapidly performed and requires minimal, if any, recovery time. But is the procedure safe? How effective is it? And how does it compare with more traditional BPH procedures like TURP and HOLEP, as well as other minimally invasive procedures like Rezum and UroLift? In order to answer these questions, we turn to an expert on the treatment of BPH. Dr. Dean Elterman is Associate Professor of Urology at the University of Toronro. Dr. Elterman completed his medical degree, followed by residency in urologic surgery at the University of Toronro. He became a Fellow of the Royal College of Physicians and Surgeons of Canada in 2011. Dr. Elterman completed a 2-year fellowship in Voiding Dysfunction, Neuro-Urology, Female Urology, and Pelvic Reconstruction at Memorial Sloan-Kettering Cancer Center and the New York Presbyterian Weill Cornell Medical College in New York City. Dr. Elterman is a member of several professional societies, including the Society of Urodynamics, Female and Pelvic Medicine and Urogenital Reconstruction, the Society of Genitourinary Reconstructive Surgeons, the International Neuromodulation Society, and the International Society of Men's Health. And now I bring you a conversation with Dr. Dean Elterman about the use of iTind for the treatment of BPH. Hello, and welcome to the Better Man Clinics. Today, we're going to be talking about iTind, a new and exciting surgical procedure for the treatment of BPH, which, as we've talked about in previous episodes, is benign prostatic hyperplasia, a problem that troubles a lot of men, making them get up at night to urinate, having slow streams, needing to push, and all of those other uncomfortable symptoms that we discussed before. But like with all new procedures, the obvious questions come up to guys considering it, such as, is this new procedure safe? What's involved with it? What are the risks? What's the recovery like? And probably most importantly, why should I choose it over the older procedures like the Roto-Rooter my doctor is always telling me about? Well, fortunately, today we have with us a true expert in the management of BPH and specifically in minimally invasive surgery for this problem. Dr. Dean Elterman is an associate professor of urology at the University of Toronro and is joining us today to talk about iTind. Dr. Elterman, welcome to the program.
Great to join you today, Oleg. It's a pleasure.
Awesome. I know the guys are pretty excited to hear about this, as we're always excited about new types of procedures. But before we do that, I want to take one step back and just ask you about you. You've developed quite a name for yourself in the urological community specific to this particular area, which is the management of BPH. What attracted you to this area and kind of as your passion in terms of your professional life?
Well, I think that men's health is a really important subject, and it affects, obviously, many of the patients who we see in our urological practice. And one of the main entry points into a urology practice is an enlarged prostate. And we know that with an aging population, it just becomes so common, so prevalent. So about half of men, by the time they reach age 50, will have an enlarged prostate, and it goes all the way up to 80% of 80-year-old men. And, for a urologist, we tend to be a pretty tech-interested kind of group. We really like innovation. We like gadgets and gizmos. And there's no better sub-area of urology, in my opinion, than BPH when it comes to new innovation. And so that's really where I've found my niche.
That's fantastic. That's fantastic. And I'm sure your patients are very thankful for that, because it's always good to approach a very common and old problem with new techniques to make things better. Now, to that extent, the first question I'm going to ask you about this is not about iTind specifically, but about the surgical treatment of BPH. There's for most people who go to their primary care doctor with BPH symptoms, they'll be started on some medication, et cetera. When should men start to consider surgery for their BPH symptoms specifically?
Well, you have to remember a couple things. Number one, BPH, or what we call lower urinary tract symptoms, which are the symptoms you experience from having a enlarged prostate, really do impact men to varying extents. And one of the main measures that we decide when to intervene and do a surgery, for example, or start any form of treatment is bother. So this idea of bother, how is this impacting your quality of life? If you are peeing perfectly well, you're sleeping through the night, and your doctor happens to say, you've got an enlarged prostate, you don't really need anything done. But if you are starting to experience the hesitation of urinary flow starting, a slow stream, it's stopping and starting, or you're not emptying, you're dribbling after you pee, you're waking up at the night, those are now affecting your quality of life. Now it's starting to bother you. And this is when you want to start getting treatment. Now, the paradigm is really shifting. We used to think, well, let's wait till the very end, at the last moment, before we offer someone surgery, because it's invasive. At least the old Roto-Rooter, as you explained. But now we're kind of flipping that on its head and saying, well, we've got these less invasive options, these minimally invasive surgical therapies or MISTs. And we also have a better understanding of the role of intervening earlier to preserve bladder function. And then, in other words, it's not just quality of life and the symptoms, but we also want to protect your bladder from being damaged, permanently damaged over time. And the earlier we intervene, we can actually prevent that damage from happening. So now we don't have to wait until the very last moment till a man is almost in retention, can't pee. We're actually able to offer treatments earlier and earlier in men who are bothered by their urinary symptoms.
Well, that is quite a change in paradigm. And I'm assuming the reason for that, or part of the reason for that, is that these newer MIST or minimally invasive surgical treatments or therapies probably have less in terms of side effects and risks than the traditional Roto-Rooter, which we'll jump into. Would that be correct?
That's absolutely correct. You know, I often think about this continuum of risk and benefit. Medications, the pills that you take, the tamsulosin, the Flomax, alpha blockers, 5-ARIs, they've got relatively low risk, but relatively mild benefit, right? We see small improvements in symptom score, small improvements in flow. On the other end of the spectrum are high risk, high reward surgeries like the TURP, the Roto-Rooter. They're really great at removing prostate tissue. Like Dr. Krambeck, the other episode, talked about enucleation. They're very good about removing a lot of tissue, making you pee exceptionally well, but they come with certain risks. Having to stay overnight, full general anesthesia, bleeding, retention, scar tissue, regrowth, etc. And so where these MISTs, these new minimally invasive procedures fall, is somewhere in the middle. They're going to be more beneficial than medications, but less risky than those traditional surgeries.
Got it. And so now let's dive into what we're actually doing. So the analogy that has been brought up in a couple of episodes now, in terms for guys to understand what we're up against, is that the prostate's like a donut and you're peeing through the donut hole. And the idea for a Roto-Rooter or a TURP, or for that matter, for the HOLEP that we talked to Dr. Krambeck about, is that we're kind of, by whatever mechanism, we're getting rid of a lot of that inner part of the donut, shaving it away, cutting it away, lasering it away, so that the only thing left is the outer, if you will, glaze of the donut rather than the donut itself. And so that leaves a much larger passageway to urinate through. How is iTind different, or is it different in terms of approaching this problem of the tight opening of the donut?
It's entirely different. This is a completely different way of thinking about improving the flow through the prostate. So other types of procedures, like you just mentioned, are removing tissue. They're ablative or resective. In other words, we're actually cutting away, removing tissue. What iTind does which is, and it stands, remember, it's an acronym, Temporary Implantable Nitinol Device, TIND. So what the iTind is doing is it's actually creating these deep incisions or grooves into what's called the bladder, neck, and prostate by inserting this temporary device into that area. And what it does is it expands very slowly over a 5 to 7 day period. And it creates these deep incisions or grooves into the prostate, essentially opening up the prostate, increasing the diameter of the passageway through the prostate without actually having to remove any tissue. So it's a cut-free way of improving flow. And so the iTind, I know we're on video, I'll try and hold one up here. The iTind is this little device with these struts, if you can see it there.
Totally.
And so there's one at 12 o'clock. There we go. One at 12, one at 5 and 7. And the idea is that they expand up at the 12, 5 and 7 o'clock. And when it's left in place, it will create these deep grooves. And then after 5, 7 days, the entire device is removed. There's nothing left over inside the prostate. This is not a permanent implant. It's not a permanent stent. It's just temporarily placed.
Well, that's definitely a paradigm shift in terms of compared to other types of procedures. But to be fair, I want to just get your take on how iTind, not in terms of results, but in terms of approach, how is it different from, let's say, a UroLift or Rezum, which also, they're not physically cutting anything away. I mean, I guess you can make an argument some way for Rezum it is, but how would you compare them in terms of approach to those other MIST procedures or minimally invasive surgical therapies?
Right. So UroLift is a permanent implant where you place these essentially sutures through the prostate to pin back the lobes. Rezum is this water steam treatment where you're injecting water heated up to kill the cells and the prostate will slowly shrink down. iTind is different in a number of ways. Number one, unlike UroLift, it's temporary. Nothing is left inside the body. You don't have to deal with foreign material and whatever complications you may have from that. Number two, it could certainly be easily repeated in the future. Number three, I would say, is that the way that it's actually delivered is very different. A UroLift and a Rezum are used with a rigid scope. In other words, it's a long instrument, telescope, that's firm. And so there's a certain degree of anesthesia or discomfort associated with putting it in. The iTind is designed to be used with a off-the-shelf flexible cystoscope. So urologists in the office have the ability to do just local anesthesia with some gel. You can pass a regular diagnostic cystoscope as you normally would, and you can actually then place through it or another channel the iTind into the bladder, and under direct vision, you can actually just pull it right back into the prostate and deploy it. So the ability to do it in the office, really truly under local anesthesia with a flexible scope with no special equipment required. The urologist doesn't have to buy a new special scope for the UroLift. They don't need to have a machine for the Rezum. It really is an off-the-shelf solution for any urologist and any patient in any practice.
Definitely sounds like a game changer in terms of approaches. I mean, it's about as minimally invasive as you can get. Now, with that being said, is the ideal candidate for iTind the same as one that would be for a TURP or Roto-Rooter, a HOLEP, or the other MIST therapies? Or because it's so minimally invasive, is it somebody, for instance, with a smaller prostate, less extensive symptoms? How does that stack up in terms of ideal candidates for iTind versus other types of surgical procedures?
I think the group of men that the iTind could be useful for is actually a very broad range. It could be men with smaller prostates who would typically be placed on medications. And this could be seen as an alternative to medication. And I think that's really where the greatest potential benefit is. You have so many hundreds of thousands, millions of men in the United States who are on these drugs. And instead of taking 1 or 2 pills every day, you could go to your urologist's office, pop this thing in 5 minutes, have it removed after 5 to 7 days, and you no longer have to take a medication. On the other end of the spectrum, there are a certain number of men who are failing drugs and who are heading towards surgery. And a good number of them could instead get an iTind. Now, there are certainly men who have much bigger prostates. And so we have a range of volume. So we usually measure prostates in cc's or milliliters or grams. So the iTind is being studied in prostates between 25 or 30 up to about 80 grams. And that's also what's being studied for UroLift and Rezum. If you're getting above 80, you're probably looking at a TURP or an enucleation. But the majority of men, probably 75, 80%, are going to be below 80 grams and would be very good candidates. The caveat for the iTind may be men who have what's called a very large median lobe. Those may not, the device may not sit properly in the prostate if you have that large ball valve median lobe.
Got it. Median lobe is that part of the prostate that pushes into the bladder, basically. And there's
From
no
the
way
floor.
there's no way to know that unless your urologist basically would do a camera test, a cystoscopy in the clinic to know that. They wouldn't know that based on your symptoms, for instance.
That's correct. But again, one of the nice things I envision about an iTind is you have urinary symptoms. You go see your urologist. They're going to say, we're going to take a look inside with the cystoscope today to make a diagnosis, a diagnostic cystoscopy. If we find that your prostate is suitable and a certain size and doesn't have that large median lobe, would you like me to pop this iTind in right here, right now, today, and you don't have to come back for a second procedure and you don't have to come for anesthesia? And then not only has cystoscopy been diagnostic, it's now becoming therapeutic. You're actually getting your treatment and your diagnosis at the very same time.
Well, you're making a pretty compelling case so far, I have to tell you. This is pretty good. Just for context, you said that the ideal size is maybe 25 to 80 grams. For context, what's the typical size of a, if you will, quote unquote, normal prostate in guys, just so they understand the range here?
Yeah. So we consider prostate enlargement to begin at 30 grams. So younger guys like me probably have a prostate less than 30 grams. Your teenagers have prostates that are like 15 grams or 20 grams. And it only starts to become enlarged after about 30 grams. So 30 to say 45, 50 would be mildly enlarged. 45, 50 to say 70 would be medium, moderately enlarged. And then the really big prostates are going to be 80 and above.
Got it. Well, by the way, I appreciate you not saying compared to older guys like me, so much appreciated there. So with iTind, you said, okay, so one of the things, what we call contraindications in medical terms, one of the situations where we're not going to use iTind is really large prostates over 80 grams. Are there any other contraindications? Are there any other type of guys or situations where you'd say, you know what, iTind is not a great idea for you? Or is that about it?
You know, I think those are the main things. The device is made out of nitinol, which is a metal alloy. So you would have to have a very rare allergy. Obviously, if there's an issue with your urethra, like a stricture, scar tissue where you couldn't get devices in and out, you cannot do any of these procedures with an active urinary tract infection. So you want to make sure that that's not the case. Probably if someone has prostatitis, so infection or inflammation of the prostate, you're not going to want to do it. But besides that, I would say that it's fairly applicable to most men who come into the urologist's office.
Do men who are on blood thinners, like those on aspirin or Coumadin or Lovenox or whatnot, or not there being too much Lovenox, but could they still get the procedure, or they have to be off of those blood thinners first?
You know, I do think it carries a risk. There's never been a specific research study that looked at men on blood thinners receiving the iTind, much like a lot of the other products. But I would say, because it is not cutting, it's only essentially stretching, that the risk of bleeding is probably very low and lower than, say, the other, even missed, where there's a needle that punctures the prostate, or with the UroLift that still punctures. So I'd say there's always a small risk of bleeding with any procedure done to the prostate, just from the mechanical pushing. But I do think the risks are relatively low.
Got it. And this is a question we hear a lot from guys. And I know you mentioned that, hey, some guys want to get off their medicine. Do men who undergo iTind still have to, in any capacity, stay on BPH medication afterwards?
The goal is no. The goal is to be able to allow men to get off of their medications. And it's our feeling, as I'm one of the investigators for the research, is that once you have an iTind, like the other mists, you should be able to come off your drugs. I usually have the men who I do the procedures on stay on their medication for about a month. And by the time they reach around 30 days after the procedure, maybe there was a little bit of swelling, so you want their Flomax to help them out for a bit, they can then stop their BPH medications. So that's definitely an advantage of doing a procedure. You can get off your drugs.
Got it. So now, now that we went through that, I want to dive a little bit into the details of kind of what the experience is. And we'll start at the very beginning. If I'm coming to your practice, Dr. Elterman, and I'm saying, you know what, I heard, I watched this Better Man Clinics podcast, sounds really cool. I'm interested in getting this iTind. What should I expect in terms of an evaluation in preparation to see if even if I qualify or if I'm a good candidate for it? What would I expect to get at the urologist's office?
Right. So when you come into your urologist's office with urinary symptoms, we're going to want to establish that it really is the prostate that is the culprit and that there's not something else going on like an overactive bladder. You have to remember that if your main symptom is like frequent urination, urgency, waking up at night with urgency, it may be a bladder issue and you may not need anything done to your prostate. Other types of evaluations may be some questionnaires. We give people questionnaires like the International Prostate Symptom Score. So it's a bunch of circles you have to, and then we add it up and see how severe your symptoms are. Sometimes what we'll do in the office is measure the velocity of your flow. So we'll get you to pee into this funny little funnel and it measures how fast you pee. And the second part of that is we'll do a little ultrasound on your lower abdomen, on your tummy, to see if you leave behind any urine in your bladder. The next thing may be either a cystoscopy, where we want to look in with the camera and see the shape, the length, the approximate size of your prostate, as well as take a look at the condition of your bladder. And increasingly, a lot of urologists are ordering some form of an ultrasound or imaging to be able to assess the size of your prostate, so the volume. And that also helps us better determine if you'd be a suitable candidate for one set of procedures versus another. So essentially the workup is talking to you, getting your history, maybe filling out some questionnaires, assessing your flow, and then assessing your prostate.
Got it. Sounds pretty comprehensive. So you mean you don't need to do a rectal exam?
I think that's sort of par for the course. Sort of like if you go to the cardiologist, they're going to listen to your heart. So yeah, we'll probably check your prostate as well.
The guys are listening in. They're like, but you can avoid the rectal exam. I love it. Okay. Sounds reasonable. So now let's say we went through the evaluation. I'm a good candidate and you're counseling me for the procedure. What are the risks of iTind that you counsel your patients on before the procedure? Right.
So the risks are going to be temporary things that you would experience while the device is in. So you could feel a pressure. Remember, this thing is opening and stretching in your prostate. So you'll feel, I don't know if it would be pain. Some men may experience it as pain or discomfort, but I think that's understandable. Blood in the urine for a few days is possible. Irritation causing frequent urination or urgency. Again, specifically for these 5 to 7 days that it's in. Anytime you do a treatment in the urinary tract, there's a risk of urinary tract infection, UTI. Those I think are the main things. There's going to be irritation, discomfort, bleeding, infection. Now there's also going to be device related things. So it does have the potential to become dislodged. It's very unlikely. It does have on the bottom of the device this little 6 o'clock leaflet, if I could show you there. There's this little bottom part that kind of holds it in place so it doesn't move forward or back. Right. There, maybe you can see it from this side.
Yeah, it's perfect.
So that holds it in place. But of course, you have the risk of migration. For men who are really living on the edge of going into retention, anything done to the urinary tract can push them into the retention. So you always have the possibility of not being able to pee once it's in. And if that were the case, we'd put in a very small catheter actually just alongside the device, leave it in for the 5 to 7 days, and then remove them both. So that's a possibility as well. Got it.
Now, those sound like pretty minor side effects. I want to run a few side effects by you that are always if you Google prostate surgery of any kind, they always come up. And a lot of these are understandably probably not applicable, but we're just going to be complete. The first one that comes up always, and this mostly comes up with prostate cancer surgery, but it's often conflated, is erectile dysfunction. Is there a risk of erectile dysfunction with iTind?
So we have analyzed the data, large research study with iTind, and we have found that there are no changes to erectile function with the iTind. In other words, your erections will remain unchanged. They're not going to get better. They're not going to get worse. Interestingly, there was a subgroup of younger men whose erections got a little bit better, but let's just say, for comprehensive sake, erections stay the same. The next question you're going to ask me is around ejaculation. And ejaculation is also 100% preserved with the iTind. So we saw no men reporting changes like retrograde or dry ejaculation or dry orgasm after the iTind. And the reason is because we are not cutting or destroying the very important structures that keep ejaculation intact. The third thing you may ask about is urinary incontinence, whether you're going to leak urine. And the answer is no. So some men have some urgency and they may have some temporary leakage while it's in, but the device is designed to sit within the prostate and it's not at the level of the muscle of control called the sphincter, and therefore it should not cause any permanent incontinence. And again, we're not cutting anything away.
Got it. Got it. So a lot of the biggie risks that we think about don't seem to apply here to iTind as well, particularly retrograde ejaculation. And my understanding is that, a lot of the missed procedures, that's one of the biggest benefits is that, men truly preserve all of their sexual function without any detriments based on that. And with iTind is that I know that for the other missed procedures, for the UroLift and the Rezum, it's not necessarily binary. There might be some decrease in the volume of ejaculate that comes out during sexual intercourse. Is that the same with iTind, or how does it compare to the other missed procedures, or is there not enough data to really analyze that?
I don't know if we've ever really drilled down to the difference between reduced ejaculate volume and lack of ejaculation, but I would think based upon how this device works, the mechanism, we really wouldn't expect much in the way of retrograde for sure, and it'd probably be fairly unlikely to have reduced ejaculate volume. But I will say, one of the things that we often don't appreciate is that just general men in the population, without having had anything done to their prostate, when they reach a certain age, it's actually fairly common in the general population to have ejaculatory problems.
Sure.
Lots of men as they age actually get reduced ejaculate volume, reduced force of ejaculation, even dry ejaculation with nothing happening to them. So that may essentially be something that's happening with age and not a result of any sort of prostate intervention.
Got it. Got it. No, that makes sense. Let's dive a little bit into the logistics. First of all, do I need to do anything to prepare in anticipation of getting an iTind procedure?
Well, depending on which practice you get it done, it may be done with some light sedation. So like if you went in to get a colonoscopy, for example, and so you may need someone to give you a ride home. That's to be expected. If you're getting local anesthetic, you're going to want to have maybe someone to pick you up and drive you home because you're going to have this device in your prostate and you may not feel very comfortable to drive. So you may want that. In terms of other preparations, you're going to get a urine test and maybe a blood test and things to just make sure you're tip top ready to go for the procedure. And that's pretty much the preparation that's required. At the end of the device, there's a string and the string goes all the way out through the tip of your penis. And what we'll do is we coil the extra string and we'll stick it onto the back of your penis, like with a little Band-Aid. And the reason is because when you come back in 5 to 7 days, we actually remove the device by pulling on the string. Now we put the string through a catheter and we actually insert the catheter and we'll pull on the string so that the device collapses like an umbrella into the catheter, and then we remove everything. That's how it gets removed. So you can expect when you leave the clinic to have this little string, and we'll tell you, please don't touch the string.
Got it. Got it. And how long does this whole procedure take to do?
It's been touted as the 5, 5, and 5 procedure. 5 minutes to put in, 5 days left in place, and 5 days to remove. Or 5 minutes to remove, excuse me. So 5 minutes in, 5 days left in, 5 minutes to remove. I would say realistically, it could be done in less than 20 minutes. I mean, by the time you're putting in your scope, you're doing freezing, you don't want your doctor rushing. And then the removal is really 5 minutes, is very quick and easy.
So with either the insertion or removal, how much discomfort should someone expect?
I think that we're manipulating a very sensitive part of the body. We're doing it under minimal anesthesia for good reasons. We want it to be quick, easy, painless. I do think you have to prepare men that this device is going to be left inside and it's going to be slowly expanding to cause these grooves. It's actually reshaping your urethra, your prostate. Mm-hmm. So I would tell men to expect some level of discomfort. And it's really subjective. I have men come in and they say, "Doc, I didn't really feel much." And that's great. And those other men who say, "Boy, I can't wait to get this out." But, it's going to end. It's only in for those 5 to 7 days. So if you can tolerate it, and obviously everyone does, you'll be fine.
Do men often take a lot of pain medicines while the device is inside during those 5 to 7 days? Do they require that?
We certainly offer it. I don't think it's a very high amount. About 20% of men will have some irritation, burning when they pee. But in the pain scores was like less than 1% of subjects in the clinical trials. So we definitely say you can take Tylenol, Advil, other types of medications. If it gets really, really severe, you can take stronger medications under the direction of your doctor, or a steroid, for example. But I haven't really had that experience.
Got it. And one thing that we hear about, like, for instance, after Rezum, is that people complain about some sloughing and they might see some tissue or something come out. Would you expect the same thing from iTind as this thing is expanding? Is it like destroying tissue that you have to pass through your urethra, or not really?
Not really. It's really a focused, almost like an incision, a groove that's being cut. The difference is, unlike a knife that cuts immediately and then it will heal shut, the whole mechanism of the iTind, which is brilliant, is that it's slowly expanding through pressure over those 5 to 7 days. And so it's almost like what we call atraumatic. And so you're making these incisions, these grooves, but you're not removing tissue and you're not really killing large chunks of tissue that are going to have to be passed out or expelled.
Got it. And during the time, these 5 to 7 days, are there any restrictions that the men have to follow? Anything they should or shouldn't do during that period of time?
Well, we tell them to take it easy. I really tell them, don't go to the gym, no exercise, no bicycle riding, obviously. I mean, people are going to feel that tightness in their prostate, and we want them just to sort of get through those 5 to 7 days without too much difficulty. No sexual activity, of course. You've got the string coming out of your penis. But those are typically the main things, the sort of physical activities that you want to restrict just for those 7 days. Once the device is out, there are no restrictions.
And do people generally just continue to work during that period of time, during the 5 to 7 days, or they're not like homebound or anything like that?
No, they're not homebound. I mean, they may want to take a couple of days off just to sort of see how they're adapting to the device. You might want to do it, say, over a weekend, but it's certainly not going to put you out on your back like like a major surgery would.
Got it. Yeah, it sounds like pretty minimal in that sense. Now, you mentioned again the complete recovery time. Basically, by those end of 5 to 7 days, you're completely recovered. So there's no recovery time beyond there, correct?
You may have some residual symptoms, again, a little bit of burning and frequency that sort of tapers off over the coming days after, but that's about it. It really is what we call self-limited. It resolves on its own very, very quickly. You're not going to have prolonged symptoms weeks and weeks after the device is removed. Got it.
Now, one criticism of the MIS procedures has been durability, right? So generally speaking, if somebody goes through the TURP or Roto-Rooter procedure, they're told, you know what, this is good for 10 or 20 years, versus if you're looking at UroLift and Rezum, and again, the data is conflicting, but sometimes people say, oh, they have to get retreated in a year or 2 years or 3 years. How does, and I know iTind is a newer procedure, but do you have any type of longish term data to understand kind of what the durability of this procedure is?
Yeah. So the big US study that was just published this year is so far just 1 year of data. There is a Italian study that's looked out to 3 years, and it looks to have pretty good similar durability to say Rezum or UroLift. It's not going to have the same durability, any of these procedures, these mists, as a TURP, as an enucleation or HOLEP, because you're not removing tissue. But I would flip this idea on its head, and I would argue that durability, the long-lasting effect of a procedure, shouldn't be the only gold standard, most important thing. I think that if a procedure like the iTind is easy to insert, fast, low risk, what's wrong with putting one in for those 5 days and getting symptom relief for 1 year, 2 years, 3 years, and then coming back and getting it repeated? We go to the dentist a couple times a year. We don't tell them that they're doing a poor job. You got to keep going back. You can think of it as maintenance, or you can think of it as an alternative to medications. Instead of taking your pill every day, you're taking your stent once a year, once every 2 or 3, 4 years. So I don't think this idea of durability is as important to these mists, because the trade-off that you're making is it's less invasive and it has lower risks. So it's easier to repeat.
So 2 follow-up questions to that. The first one is that with Roto-Rooter or TURP, doing a repeat Roto-Rooter and TURP tends to have some added risk to it. The anatomy is a little bit different. There could be a higher risk of incontinence because of what you're doing. You're cutting things away and the landmarks aren't quite there. Do you face similar added risk by, if you will, re-iTinding or doing another procedure after an iTind?
So this hasn't specifically been studied, but my expert opinion is that no. I mean, I think what you've done is you've made these incisions, you've reshaped the prostate, and over time, if those incisions or grooves starts to close up or the prostate starts to continue to grow, there's no reason why you can't reintroduce an iTind, have it do its thing for those 5 to 7 days, and see how it goes. If you are beyond the point where the iTind or any other mist is achieving the effect you want, then maybe it is time to go for a Roto-Rooter or something similar. But there's no reason that you can't retry it and see how you go.
And similarly, I mean, this is probably self-evident, but just to be fully clear, one of the issues of redoing after, for instance, UroLift, there's been concerns, at least mentioned, although this is debated, that because there's actual something left over, it's hard to do a Roto-Rooter. You're going to be hitting these anchors or these sutures or whatnot. I'm assuming with iTind, there's nothing left over, so that shouldn't impact. If you actually did want to get a TURP or a Roto-Rooter, there would be nothing preventing the surgeon from doing an excellent Roto-Rooter on you.
That's exactly correct, Oleg. I mean, one of the beautiful things about a device like an iTind is that because it's temporary, it's doing its work over those 7 days and then it's entirely gone. And it will not interfere with any future procedures. So it keeps all your doors open. All procedures are options in the future if you would need them. And there's no foreign body left inside your prostate.
Got it. Now, the $6 million question.
Mm-hmm.
This get ready. We started this conversation because why are men getting this? Bother, symptoms, discomfort. How does iTind, and if to the extent that the data is available, in terms of outcomes, not in terms of side effects or redos or whatnot, but in terms of actual satisfaction from the patient side, from the guy saying, you know what, I'm peeing like a racehorse now, I feel better. How does iTind compare head to head versus, number one, the gold standard, which is the Roto-Rooter or TURP, and number two, against the other missed procedures like Rezum or UroLift?
So it appears to be very similar to the other missed procedures. We see, those circles that you fill out that questionnaire called the IPSS. Yes. In the large clinical trials that have been done with the iTind, there's been 3 of them. We see the IPSS score reduced by between 45 to 60%. So
and just to interrupt you for one quick second. So that means that their symptoms have improved, if you will, by 45 to 60%.
That is correct. So we see a significant improvement there. We see the force of their flow double. And when we look at quality of life, we see their score also significantly improve from a score where they're generally dissatisfied to a score where they are satisfied. So on the IPSS, it's a 5 points. They go from a 4, which is not very good, to about a 1.5, 2, which is quite good. So we see that. And I think that's very much similar to the other mists. Now with TURP and enucleation and Roto-Rooter, you're going to see a more dramatic improvement in flow, in the symptom score, maybe a little bit in the quality of life, but that's debatable. But that's because you're doing a more invasive operation where you're really taking away a lot of tissue. So again, that's that trade-off of the degree of improvement you're going to see and how long it's going to last, but it's invasiveness. But the iTind certainly holds up just as good as those other minimally invasive products that are on the market.
Yeah, I would say 45 to 60% is a pretty respectable improvement for something that's going to literally give you minimal risk as compared to the other procedures. I think that's respectable for sure and reasonable. Now, you've mentioned several times about, obviously we've mentioned this is a new procedure. You mentioned that you're doing research on this. How many of these procedures have been done, not only by you, but in general?
Let's see, I have like my little cheat sheet up here. So we're looking in the clinical trials, there being close to 300 patients treated in all of the different clinical trials when you put them together. The device is being commercially available in Europe for a number of years, as well as Canada. So, I was doing these outside of the trial, and they're available in Germany and Italy and other parts of the world. So I don't have an exact number. It's not in the tens of thousands, but it's certainly in the hundreds, if not thousands by now. And to be clear, it just received FDA approval in, I want to say March of 2020, middle of the pandemic. And it's really only getting commercially launched in the United States now. And so that's why we don't have very high numbers. This is really coming right onto the scene as we speak.
And again, it's interesting because I just had a conversation with somebody about ED treatments, and they said it's FDA approved, wink, wink, but it's not really. This is truly FDA approved. So it's not considered experimental anymore.
This is not experimental. This has full FDA clearance for the treatment of BPH in men. This is the treatment. It's not some off-label experimental treatment. This has received full approval from the FDA. Absolutely.
So that being said, an important follow-up question is, if I'm a guy interested in iTind, how do I find somebody to do iTind for me or to perform the iTind for me, aside from going to Toronto, which is always an option?
It's a lovely place. And before it got FDA approval, we had a lot of Americans coming up to Toronto to get the iTind. So I've had my fair share.
I can imagine.
So iTind has a website. I think it's probably iTind, itind.com if I had to guess, but it is carried by a company called Olympus. And I think you could probably go onto the Olympus Americas website. They may start to have something called a physician locator. So a lot of these companies, you can look up physicians who offer that particular product. But definitely you can contact the company, maybe look on the physician locator. But definitely there are people who are now offering the iTind in major cities around the United States. It's available in California, Los Angeles, Bay Area, New York, Texas. And every week there's a new person who is adopting it in their practice.
And presumably if they show up on one of those websites, they're, if you will, quote unquote, certified, meaning that they have the experience to do it. It's not just somebody just trying it out and seeing what happens.
No, that's correct. I mean, I think that, Olympus, like many, are a very responsible company, and there's a certain level of training and proctorship and understanding the safe and best practices and how to do it. So a doctor can't just order it and just start doing it on their own. There's a process involved, and the same is true for UroLift and Rezum and everything else, where you need to get some level of training and expertise to be certified. And so that's no different for the iTind.
Got it. Any special questions that you would recommend patients asking a prospective surgeon that will be performing the iTind? Anything in terms of vetting, or any questions that would help them get comfortable with the surgeon and or the procedure that you would recommend?
One of the things that I think is really remarkable about iTind is that it relies upon basic skills that urologists have. And so I don't think you need to grill your urologist and say, how many have you done? And, how would experience, because we have all, urologists are very familiar using a rigid scope, flexible scope. We put wires into the guide wires. We put baskets to get stones. We put lasers. So this is no different than the basic skill set. It's not special technique that has to be learned with a big fellowship or special training where they have to fly somewhere to learn. So I wouldn't be too hard on your surgeon, on your urologist. I think that it's very much a basic skill, which is what's one of the great things about it. You can ask them what's their preferred method of anesthesia. Would they like to do it under local anesthetic? Would they prefer to do it with a little bit of sedation? Some urologists are doing it with a rigid scope under sedation, which is perfectly acceptable. Some urologists are starting to adopt a newer technique where we use the flexible scope to put it in. I don't think that should dissuade you one way or the other. But that's about it. You'll ask them, what are the medications you'll give me over those 5 to 7 days? And then what's the procedure like to have it removed? And they'll explain it. But it's a very straightforward procedure, start to finish.
Got it. So last question, and this is probably the most difficult one. You are not an iTindologist. You're a very skilled urologist. You're an expert on BPH. You do basically all of these procedures, the MIST procedures, the TURP. If I'm a patient walking into your clinic, I have a appropriately sized prostate. I'm very bothered by my symptoms. I don't want to be on medication anymore, otherwise known as the perfect patient for surgery, for a surgical treatment for BPH. You have all of these at your disposal. What do you counsel me? What do you tell me?
Well, counseling has become increasingly more complicated because we now have so many options. And for someone like me who offers all of them,
right,
it's not so straightforward. The way that I would divide it is I want to be very systematic with the patient. We want to try and do a tailor-made, customized treatment for each individual man. Okay. And so the things that I'm going to ask you about, we've already established your prostate's the right size, you've got the right symptoms. I'm going to ask you, how do you feel about where I do this? Do you want it in an operating room or do you want it in the hospital? Do you want to be fully asleep or do you want to do it awake? Do you care about keeping your erections and ejaculation, or would you be okay to lose them? How do you feel about having a permanent implant in your body versus steam or an iTind, which is removed? Are you someone who is pretty good about tolerating discomfort? This device is going to be in for 5 to 7 days, or are you a little bit of a chicken and you don't like that and you would rather just have something that's done and you won't feel? So those are some of the questions I'm going to ask, and hopefully we'll get to a decision between the two of us. But there is admittedly a lot of overlap. There isn't a perfect patient for iTind. There isn't a perfect patient for Rezum or UroLift. The perfect patient is probably a good candidate for any of them. So I'm trying to be very balanced and even-handed. I perform UroLift, I perform Rezum, I perform iTind. So I'm very open, I'm agnostic. But I think that the iTind has a lot of features that will be appealing to men, and ultimately it's going to be what they feel in their gut. That's what they're going to go with.
I actually love that. I think that it's so amazing that, myself being a urologist where, 15, 20 years ago, the options were at that point where not the homing, but the other laser was the novel thing. The PVP was the novel thing where you really didn't have choices, right? It was just basically a rotor for all intents and purposes. It's amazing the level to which, again, this is its own level of precision medicine where because this is a problem of bother, it's not cancer, it's not like a heart attack, it's a problem of bother, you really can tailor the treatment to the specific nuance, needs, and, if you will, personality of the individual patient, which is fantastic, because then you're really getting what you sign up for, and you're understanding the trade-offs ahead of time, and you can really laser focus. No push for HOLEP here. You can be laser precise in terms of what type of procedure you do. Dr. Elterman, thank you so much. That is extremely helpful. I'm going to leave you with a question that has nothing to do with the prostate whatsoever, but I ask all of our experts at the conclusion of our interviews. This podcast is called Better Man Clinics, because we're not only getting better in terms of health, we're getting better in terms of our entire lives and way of life. And when we interview our experts, they're inevitably successful, and they've reached a level of success in their lives that others would like to emulate. So the question I have for you is, how do you become your best self? What's your secret to your success?
Having an amazing family,
That helps.
a supportive partner, and my wife, and making sure that I balance time with my kids, but also remaining curious. I mean, I think that one of the greatest aspects of a successful career is not resting on your laurels. It's staying curious, and it's about pushing forward. And I've sort of made a very conscious decision to be at that forefront of that innovation curve and be what's called an early adopter. And that's the reason why I'm in academic medicine, where I'm teaching residents and fellows and students, because they keep me on my toes and they keep me curious because they're asking me questions. And so, strong mind, curiosity, healthy body, getting on my Peloton, and a healthy heart, spending time with my family. So I think that's the secret to my success.
I think that's another very tailored and excellent approach to overall well-being. Dr. Elterman, thank you so much. This was an extremely informative and a fun interview. And to all you guys out there, thank you for watching and listening. And remember our motto here at Better Man Clinics: your best life is a journey and not a destination, and use every single day to get just a little bit better. We'll catch you next time.